So, Falcha, and welcome everyone. Welcome to our second webinar here this year. The Irish Society for Disability and Oral Health here are delighted to welcome Dr. Harriet Byrne to speak on medication-related osteonecrosis of the jaw. So Harriet graduated with me, actually, with a Bachelor in Dental Science from Trinity College Dublin in 2017, followed by extensive clinical experience across multiple institutions in Ireland and the UK. And then she earned her RCS membership in oral surgery from Edinburgh in 2023 and completed her clinical doctorate in oral surgery from UCC with a first class honours in 2024, which does not surprise me because I worked with Harriet for a year or two in the past in the Dublin Dental Hospital. And one of the things that I've always admired and always stuck out to me, Harriet, was how you managed to balance everything in your life. So you had hobbies coming out of your ears and ponies coming out of your ears, and you still managed to do really well clinically and academically and have a social life despite all of that. So fair play. And subsequent to that, then her doctoral research focused on the oral health status and dental care needs of oncology patients receiving bone modifying agents, which is so befitting of this webinar here. So we're very, very honored to have her here this evening. So Harriet's talk will explore current knowledge of MRONJ, the gaps in our understanding, and the best practices for managing patients on bone modifying agents, which is becoming an increasingly complex area of dentistry. Just a little bit of housekeeping. The questions, if you can please ask them throughout the webinar, but will be answered at the end. So feel free to just pop them in the Q&A bar down below. So feel free to familiarize yourself with that bar. You can put, if you still don't have a question, you can put a chat down in the chat icon. And, it'd be great to have some kind of feedback between the attendees through the chat box, sharing your expertise, sharing your experience. And at the end, if you want to raise your hand and have something to say verbally, feel free to do so. And some people might see that there's a closed captioning available for in case you require it. I think some people just need to press the closed caption, the CC button down at the bottom. But without further ado, as Harriet's setting up her webinar to share, I would like to introduce you to Dr. Harriet Byrne. Take it away, Harriet. Thank you.
Hey. Thanks, Ahmed. I won't delay. I am very impressed there's 83 people here on a Wednesday evening to listen to me about MRONJ. So yeah, God, that's a privilege. I'm usually used to yabbering away to dental students. So I said, God, this is going to be a little bit of a different experience. So we're talking to the educated now. So look, I'll start away, as Ahmed said, ask questions. I want this to be a learning experience more so than, a lecture, I suppose. MRONJ, it's only been around the last 20 something years, so there's loads of things that are missing. There's a few things that we do know about, and hopefully I can kind of show you where we started with MRONJ and where we are now. So I'd like to make a special thank you to Claire Curtin, who's roped me into this too. So yeah, thanks, Claire. So listen, who am I? I am Harriet. As Ahmed said, I graduated in Trinity 2017, was around Dublin, Cork, Cardiff, St. James's, Crumlin, doing essentially max fax jobs. Knew I wanted to do oral surgery, and I started that in 21, and then obviously I graduated as an oral surgeon in 24. I'd say this is the start of the road, so obviously it's kind of where I've landed on what I want to do, but Yeah, it'll be interesting. But look, I've seen loads of MRONJ between all these different years from a preventative and a treatment point of view. So hopefully I can just, give you a taste of the tip of the iceberg of the reality of it. I'll give one thing. These are my own thoughts, my own personal opinions. It's great, the literature, you can challenge many things that I suppose I put forward here. And that's the good thing about, I suppose, these discussions is we can see the pros and the cons. I might learn something new as well. So what are we going to do? We have 4 volumes to get through. We have, I suppose, MRONJ. I don't want to lecture you. Everyone can read Google. You can understand what MRONJ is. I actually want to just get stuck into the daily things that we see. So thinking about when people ask you an opinion, you're talking about the extraction. Definitely, it's the most traumatic thing we'll do to the alveolus and dentists alike. So we'll talk about the extraction. I'll show you how I personally manage patients who've been on bone modifying agents, and maybe you might pick up some tricks. Something that lies very dear to my heart is prevention. So I quickly found out that we can't treat MRONJ effectively. There is no, I suppose, there's no pill, there's no surgery, there's no predictable way that I can say to a person, I can cure you. So that, I was quick. It was very easy to think of how are we going to stop these people, that have cancer, gone through their treatment, and now they have this, stage 2 MRONJ. You have to prevent it. And that's, I'll dip into a little bit of research we did, but that lies dearly to me. And that's the strongest column of evidence that we have on MRONJ. Then we move on to volume 3. So to me, it's a 50 shades of grey job. That is the definition of the literature when it comes to treating, managing, even advice on how to approach MRONJ and patients that are at risk of it. There is avenues that go in all directions. And to be quite honest, there is a very, very scant amount of actual evidence that can tell us this is the right thing to do. And then suddenly we're in 2025. Where are we now at MRONJ? So let's get going. As I said, I want to plant a seed. I hope people pick up a little bit of enthusiasm, a little bit of confidence when it comes to treating patients with MRONJ. There's no great complexity to this, and that's what people, I suppose, maybe stumble over a little bit, having a little bit of confidence, direction, and learning some things tonight might just give you a few little bit more of an, I suppose, an armamentarium to actually deal with these patients. They're not rare. There's so many people on bone modifying agents through the spectrums from osteoporosis up to bone mets. So there's huge array of people in there, and we all have to be very open to looking at them, treating with them, and that's where we go. So look, we need to define it. MRONJ, they have to have an anti-resorptive or an anti-angiogenic exposure. They have to have, ideally there is exposed bone, but sometimes, very rarely, there's a stage 0 that we don't have an exposure of the bone. But by and large, there's exposed bone. It's there for at least 8 weeks. So if someone rings me up and says, listen, this lady was on Zamita, the socket isn't healing, and I took out the tooth a month ago. Well, it isn't MRONJ yet. You need to keep an eye on it. These people, they've probably had chemo, they're probably on steroids, things are slow to heal. And the reassuring part is that not everyone, actually 1/10 of patients, so 1 in 10 that actually has been on a bone modifying agent will get MRONJ. So the other 9 will walk out at 8 weeks with a healed socket, and that's a good thing. Obviously, patients can't have radiation therapy. They can't have, disease or bony mets. Ideally, you don't want to be treating this MRONJ that actually is, a bone met from their breast cancer. Anything, any sample that comes out of the body goes to histopath. And with MRONJ, just because it's bone doesn't mean that it shouldn't be assessed, and that's very important. When you look at, I suppose, there's loads of different types of, I suppose there's loads of different communities, like the Cochrane, the Americans, the Europeans. There's loads of people that look at how do we define MRONJ. Definitely, in my opinion, the Americans are the most consistent and reliable. So stage 0 is obviously no bone, but you've excluded all other pathology that lead you down to the MRONJ route. Stage 1 and stage 2 are essentially the same thing, except in stage 2 it's infected. So if there's pus, if there's erythema, listen, we're into stage 2. We have another layer of challenge, which is this, I suppose we're losing the battle when it comes to the microbes in there. So stage 2 is infected. Stage 3 you do not want to see. Beyond the alveolus, through the mandible potentially, up into the sinus, large expanse of bone usually, and they are horrendously difficult to treat, particularly when you think of these patients, the patients that are likely to be on IV, bisphosphonates or the oncology regime are going to be unwell. And that's a big thing. So look, the AOMS, this defines where we lead our strategy and how do we approach the patient. So, right, before we get actually stuck into what we're going to talk about, there's two types of patients. MRONJ is MRONJ, but the patient is very different. So in my opinion, when I see someone come in, I am not thinking about what size the exposed bone is, where is it, how long has it been there? I'm thinking about who's it in. Is this patient healthy? Have they had, osteoporosis for the last million years? They've been on oral bisphosphonates and their DEXA scan is staying solid, and suddenly we have a non-healing socket. The other side of things are, apart from their bony, I suppose, medical history, how healthy are these patients? Do they have a heap of comorbidities? Have they other exacerbation factors like smoking, massive, a denture that's loose, chronic periodontal disease that is just, all of these little factors actually tip the balance. Whether it's, they've been on bisphosphonates for 3 or 4 years is kind of irrelevant, but if it's in an uncontrolled diabetic, very irrelevant, very relevant. The other patient is the oncology patient, and by and large, they jump up into this high-risk group because the potency of the drug they've been on is obviously 100-time fold. They've been getting it more frequently. Probably they've started this treatment not in a rush, but in an oncology regime where maybe dentistry doesn't take the role it should. So they've finished chemo, they've finished radiation therapy, and suddenly we're starting a bone modifying agent. This is also relevant then because these patients won't be healthy. They'll probably have, previous steroid therapy because as a part of their oncology regime, or, again, the exacerbation factors like someone who's smoking, all of these things add up to give you the risk of MRONJ. Obviously, orals over 5 years, that's what's quoted. But personally, to me, the substrate on who you're actually dealing with is incredibly important. So we will hit volume 1, which is the extraction, which is, I suppose, the nuts and bolts of patients on bisphosphonates and when they come into trouble. The big thing for me, as I said, is who you're actually dealing with, because when you think of it, it's a healing capacity or a lack thereof that allows MRONJ to develop. So if someone's come off chemotherapy or they've been on, a month of steroids, if their diabetes, if it has completely been off the charts, they're going to be the patient that's going to, their wound is going to break down. They're not going to be able to win that battle. I just find anyone with a medical condition that is not behaving or out of control, these patients won't be, I suppose, at their best to fight an infection. So you could even think of, like, it doesn't need to be oncology based. You could think of someone who has Crohn's. So they might have had, a bad bout of Crohn's. They've probably been on a biologic. They might be taking, a couple of weeks of steroids just to settle things down, or they might be changing their biologic. All of this upset, all of this, I suppose, biological treatment, immunosuppressive therapy will kick you onto the road of, oh, this patient actually is a little bit more risky than someone fit and healthy with osteoporosis. Obviously, the oncology cohort, what comes with cancer is bone metastases for a lot of them, and then the stages. So for me, there's two types of oncology patients. We have the people that are going to live a long time, stage 2, and the people that probably won't live as long, but are on a higher regime of bone modifying agents. And personally, the patients that, in my opinion, have are a little bit, I suppose, on the back burners are the patients that get IV bisphosphonates, not every month because they're stage 4, but every 6 months. And these are, the 40-year-old breast cancer patients. They've had surgery, they've had chemotherapy, and there's a preventative role for bone modifying agents to stop recurrence. So they've not gone on Zometa because they have a bone metastasis. They've gone on Zometa because it has shown, it's in bone oncology guidelines, it reduces the risk of a recurrence in the bone. And they're the people that are going to live for the next 20, 30, 40 years that are at a high risk of MRONJ that need to be seen by a dental service every 3 to 6 months. Rheumatology, it's a funny one. They are the people that actually prescribe a heap of bone modifying agents. So, people with osteoporosis, people with rheumatoid arthritis, spondylosing ankylosing, all of these drugs either need bone bisphosphonates or they need bone modifying agents like a biologic. Now, obviously, it is a lower risk to get MRONJ with these medications, but by and large, they are a risk factor. And rheumatology is a cohort that kind of brews away at itself, but they are at risk. Social history, we all know. I feel like I'm talking to 50-year dental students, but the reality is that if this person is smoking, I completely alter my expectations. So we take out a lower 6 and a smoker and a non-smoker. Unfortunately, if I was in Paddy Powers, I'd be putting my bet on the smoker. Support at home. So we see loads of people that come in. They don't have anyone to take them to dental appointments. They don't have access. They don't have finance. They don't have motivation. They have a heap of barriers to care. Like we've seen so many, refugees and people that have no access to phones, the English language, and all these factors, all of these blocks that get in the way of proper treatment are a factor. So they need to be noted. Again, the dental home, so you'll see in a little bit, the reason why there's no massive RCTs or randomized control trials about MRONJ is because we can't ethically get to cause it. So we don't know how we can treat it effectively, or we don't know the big factors that cause it. In my mind, if someone has a high dental treatment need, and you'll see in a little second, if someone needs 9 teeth out because of periodontal disease compared to the person B that needs absolutely no teeth out, that has excellent periodontal health, the measurement of a person's treatment need is an indirect indication of their potential to develop MRONJ. And knowing a person's dental motivation, their history, their prior intervention. So you kind of think of patients that, see a dentist every 6 months, they're not going to be in the bracket, hopefully, that need a tooth out compared to, people that haven't seen dentists in years. The time, obviously, is a big thing. And are people transitioning? So we often see patients that need to go on a bisphosphonate in 2 months. Not even 2 months, you might have a month to get them fit. How are you going to get periodontal disease, 4 teeth extracted, transition them onto a denture and say, absolutely, they are dentally fit, crack on? That time limit is lethal, and that's where bisphosphonates that's where the dental care and bisphosphonates sort of, I suppose, they conflict a little bit. Again, if someone's on bisphosphonates for oncology reasons compared to osteoporosis, the potency of the drug, the administration, if it's IV bisphosphonates every month compared to orals every week or every day, they're two different animals, in my opinion, high in the low risk group. Again, the timing of the treatment, are we compromised from reaching dental care? And obviously, if patients are on an anti-resorbative, which affects the bone, and an anti-angiogenic, which affects the blood vessels, both of those are really giving the patient competition to not heal compared to someone who's on a low-grade biologic that might just affect blood vessel formation. It's about the insult to the bone as well. So there's an absolute heap of drugs that patients are on. So we know our bisphosphonates, we know our Prolia, that's fine. Then there's the next two groups, which are they affect the soft tissues in my mind. So that's, anti-angiogenics. Patients can be given them for oncology reasons. They can be on them for a heap of reasons, like biologics as well, infliximab, rituximab, all of the AMABs, they affect the immune system in some way. They affect interleukins, that's going to affect the body healing. That's going to impact, I suppose, the potential to cause MRONJ. Adjuvant therapies as well, that's in my head. People who are on steroids, people who's on, methotrexate from rheumatology, these have been associated with, I suppose, an additive effect with bisphosphonates to cause MRONJ, or there are case reports that you can get MRONJ with them on their own. I'm not going to get into them because we rarely see them, and if you do see them, the risk of MRONJ is less with them. So let's look at these two guys, our usuals. And, oh God, when I said, right, how are we going to do? We're not pharmacists here. We're not going to go into, this massive mode of action with these two medications. We're going to make it, I suppose, I like one slide. I like doing pictures, and that's how I work. But hopefully this slide will try clear things up a little bit. In the middle, we have bone remodeling. And unfortunately, we need to talk about this if it comes to MRONJ. Bone remodeling, this is when you take out a tooth, the alveolus remodels, and we all know the denture and the patient who has that sharp spicular bone, and we wait for the body to deal with it if we can't. That process is kicked into place by pre-osteoclasts, or this cycle of getting rid of old bone and then making new bone. So if we don't have the cycle of getting rid of the old bone, we can't make new bone. And that's why MRONJ, the cyclical process of making MRONJ or making new bone, doesn't happen. You need viable cells. You need pre-osteoclasts. These are the guys that are sitting in the corner waiting to get a signal to say, listen, turn yourself into an adult now. You're an osteoclast. You need to get rid of this old jagged bone, and we need to kickstart the process of bone remodeling. Osteoblasts, they obviously clip into work then, and they start to form new bone. And a lot of this is regulated by cytokines and growth factors. So that's the happy family. Then what you do is you add the two anti-resorptives. So if we look at bisphosphonates, these are the classic anti-resorptive. There's nitrogen, non-nitrogen containing, and essentially there's an enzyme. Call this enzyme here. And what this does is it essentially stops osteoclasts sticking to the bone. So this is actually involved in cholesterol synthesis, but it stops osteoclasts sticking to the bone. If the osteoclasts aren't sticking to the bone, they die. They can't work. So that's literally what happens. Bisphosphonates cause osteoclasts to die. Grand. So here we are. We have our happy cells, and we no longer have a viable osteoclast. So that means we can't form bone. On the other side of things, we have pre-osteoclasts that react to cytokines. There's a few of them. There's rank ligand, and there's OPG as well. And they're all involved in kickstarting osteoclasts into action. So getting them moving, getting them started. If that loss of communication happens, osteoclasts won't work. So on the left, we have dead osteoclasts, and on the right, we have disabled osteoclasts. And both of those stop the bone remodeling. So hence, a socket can't heal. And that's the bottom line. So listen, it's a matter of time. Hopefully it's not a matter of time when it comes to MRONJ. But in the case of this slide, there is time-sensitive, I suppose, beings. One, an irreversible binding of bisphosphonate isn't a matter of time. Once a bisphosphonate reaches the osteoclast, it's there for about 11 years. Time is irrelevant. But we have the ability for, time-sensitive nature when it comes to dealing with RANKL inhibitors or Prolia denosumab. And that's advantageous when it comes to fitting in the extraction. So when you look at denosumab, that's fine. Everyone's usually going to be on it in Ireland for osteoporotic reasons because we actually can't afford it in the oncology cohort. It's too expensive. We'd love to have patients from oncology on Prolia, but unfortunately it's not funded. Some prostate cancer patients get it, but breast, no. So what we want to do is we want to pick up we want to take out the tooth when the least amount of osteoclasts are affected. So that's in month 5. Month 5, take out your tooth, leave it for 4 weeks. Now, you don't just kick the patient to touch, you get them back in 2 weeks, you get them back in 4 weeks. And at that point, you send oncology or the doctor a letter to say, absolutely, we have mucosal coverage. And that's, I suppose, the green light. That's the goal of treating MRONJ, is mucosal coverage. If the bone has blood, it can survive. So correspondence is incredibly important when it comes to this, because the timing of Prolia is very sensitive. You need to be on the ball with talking to the GP. And the reason I say that is everyone's on top of it in month 5. So God, we can't take it out in month 2. That's fabulous. But no one thinks of month 7, 8, and 9, because what happens, and there's so many studies to say that if people delay or they remove that 6-monthly cycle of denosumab, your bone mineral density falls through the boots. So this is a patient that's been on denosumab. They stop getting it, and suddenly you can see a spiral, and it's spiral fractures they get. You can get catastrophic fractures if a patient doesn't go back on their Prolia. So talking to the doctor and telling them month 5 we'll take out the tooth, I'll give you the go ahead in month 6 and get them on it. Bisphosphonates, unfortunately, it's an irreversible apoptosis. We can't do anything about it. We don't have a window of opportunity. 4 weeks must be present for healing. That's fine. And in the case of diagnosing MRONJ, hopefully not, we definitely see them on 2 weeks, 4 weeks, and 8 weeks. And correspondence to the oncologist or the GP then, if we have mucosal coverage, we can crack on and give them their medication. You can see it's over 10 years that a bisphosphonate is within the bone, latched on, and has affected that osteoclast. So that's very important. I alluded to the fact that it's not what, but within who. If a patient is very much uncontrolled, isn't the healthiest, is smoking, and obviously it's a bigger tooth in the mandible, in the posterior mandible, they're all factors that kind of heighten my awareness to say, oh, we might just tread a little more carefully here. I'm not going to go through this, but what it is a demonstration of the literature of what studies are available for bisphosphonates that are used in the adjuvant. So when a patient has had their oncology treatment, these patients are put on preventative bisphosphonates. And these are young people, and they are at risk of MRONJ. And it's very important because there's actually not a whole heap of talk nor study about it, but they've been on IV bisphosphonates. They're getting it every 6 months, so they are a high risk, and don't forget about them. I put up this slide because this is, I suppose, these are the guidance that I looked at, and these are the guidance that are available to people to use. And unfortunately, when we get to the 50 Shades of Grey, you'll see that there's not a whole heap of cohesion between any of them. They all take their own slant, they all take their own principles, they all base their theories on like evidence that's available, but unfortunately none of it is high quality, if a small bit of it. And then suddenly we're left in the scenario that we have to take out a tooth, this clinical obligation to treat a patient within this fear of MRONJ, of dealing with MRONJ. So we'll see in a little bit how this conundrum can affect people, and how it can, we really have one hand behind our back because all of these guidance are saying different things. So let's do the tooth, the extraction. So someone comes in, they say, listen, Harriet, I've been on bisphosphonates for 4 years, like this lady in a second, and I need a tooth out. It's a lower molar. Fine. So the thorough workup includes the medical, social, dental, the bisphosphonate, or the BMA history, and that's imperative. That will tell us how we're dealing with this. These are my controversies. There are American guidelines that say 5 days before and after there's chlorhexidine and antibiotics. Personally, I do that. I think that the morbidity associated with MRONJ, particularly in patients that have had, a history of oncology treatment, is it's catastrophic. And for the fact that we're giving them, 10 days of antibiotics to give us a boost to help things heal, personally, I think it's worth it. All teeth are surgical extractions. And you'll see why in a little second. And one of the things that the literature agrees with is when you take out a tooth, you have to close it primarily. So primary closure means that you get the gum from the lingual and the buccal side to nearly, oppose each other. That's very difficult to do. So we'll see in a sec. And then, like everything, we do not just kick the patient to touch. We review them on 2 weeks. We review them 4 and 8 weeks. And we're cleaning, we're seeing, maybe on week 2, their oral hygiene is horrendous. We might bring them in 3 weeks. You gauge how the patient is responding to everything, and that will allow you to dictate how you manage them. So this is Anya, lovely lady. She was in last Thursday, and she is one of our stage 2 breast cancer patients. So she's gone through all her treatment. She's got the go ahead. She's fine, and they're putting her on preventative bone modifying agents to hopefully, that she doesn't get a recurrence or a bone met. And it's her lower left 6 that we're taking out. So I was like, that's fine. She's been on bone treatment, so I have the same routine for everyone. I don't care who they are, whether they've been on, osteoporosis, indicating medication, or whether they've had stage 4 breast cancer. They're all the same. So you can see this is the lower left 6. There's an old amalgam. There's no buccal wall, essentially. There's a temporary Fuji probably in there. So I know people are going to put on a cow horns and that and say, sure, it'll come out. We'll use the criers and get out the distal root, and sure, there's Anya gone now and her tooth is gone, delighted. No. So you'll have a look again, really thin lingual wall. This is going to crack. This is not going to be predictable. And what we want in MRONJ extractions is predictability. We want this to heal well, and we want to give it a chance. So again, I'm just showing you, this is a classic lower first molar. It's a posterior, larger tooth that is going to increase your risk of MRONJ compared to an upper central incisor. So what do we do? Everyone gets a flap. You'll see here, the design of the flap is we're going just along the gingival margin. This papillae and the distal papillae are raised, and we're going to relieve this papillae as well, because what always happens is you don't bother and then it tears here, and then suddenly they've recession on their lower premolar. So, I mean, this doesn't, personally, raising this flap is something that I suppose it depends on your competency, but really getting the scalpel in there and just raising this nicely is okay. You can see then when we raise a little flap, we're not pulling back a heap of gingival tissue. This is relieved but not raised because we reduce the tension here. And what we want to find is we want to find the furcation. So this is where we're going to aim for with our drill, to take this tooth out as carefully and as predictably as we possibly can. So let's have a little look. We section the tooth, bit of the temporary filling has come off, grand. We're gone straight through the furcation, and what no one does is go deep enough. So I am coming to cancellous bone in here, and this has gone through the furcation. So I'm happy that this tooth is sectioned into 2 roots. Take out the tooth. There's no fracture of the bone. What will happen in cases of MRONJ is that you'll have a fracture of the lingual plate, you'll have a fracture of the buccal bone, you'll put your cow horns on, and things aren't debrided. You're not giving the body half a chance. What the osteoclast should do is get involved and get rid of this furcational bone. But we know in Anya it won't. So when she's been exposed to bisphosphonates, these osteoclasts are not going to deal with this, and this is why MRONJ will develop, because you'll have poorly vascularized bone that becomes, I suppose, necrotic essentially. So what we need to do is take down the bone. So I've gotten a round burr and I've completely taken down the furcational bone. And you might be like, Harriet, that doesn't look like you've done anything. This is what it was, and this is what it is now. I've completely taken down the furcational bone. Not only have I taken down the furcational bone, I've taken down the buccal bone. I've completely taken it down all the way around. We've no sharp, jagged edges. We've nice, clean margins. And this has probably gone down about 3 to 4 millimeters at least. So not only will this gingiva come over more freely, we are able to suture it closed. with a really good blood supply on top of it, completely encasing the blood clot and giving that socket a tensionless, I suppose, environment to heal with a good blood supply. And that is what I do for every tooth. It is so basic, it's so simple. But rather than just putting a cow horns on that tooth and saying, listen, away you go, Anya, your tooth is gone, you'll be fine, we'll see you in a month. No. So the extraction, you should be, it's something that people can deal with. So the next thing then we're looking at is prevention. That is complete protection for the patient. In my view, this is the best study that exists for MRONJ. It's a randomized control trial that's present that actually doesn't look at MRONJ directly, but it's a dosing regime from 4 weeks to 12 weeks. They want to give less bisphosphonates essentially in the cancer patients, and they looked at introducing dental clearance reviews and preventative measures before they start the bisphosphonate and during their treatment as well. So actually what we saw was that there was a 50% reduction in MRONJ when they started doing a pre-dental clearance and preventative measures throughout. Fabulous. This is the strongest bit of evidence I think personally there is for MRONJ. Prevention is key. Prevention works. Half of those people didn't get MRONJ because we took out the teeth that needed to go beforehand. We kept an eye, we had fluoride, we had OHI. They were enthusiastic, people were motivated. They were, all of these little interventions are huge. Obviously, patients got less bisphosphonate, but when you're getting intravenous bisphosphonate every month or 3 months, given the nature, the potency, the half-life, I think it's very promising. I think it's very conclusive that there definitely is a role for the dentist and there's definitely a role preventive therapies here. Again, another important study from Sloan Kettering. Patients, this was a retrospective review compared to the other randomized control trial. Patients essentially had MRONJ, but the second group, the data set that they looked at, actually got a dental evaluation and preventative treatment before they started the drug. And now obviously they didn't have even numbers, but we'll see here that we're dealing with a case control study, which is fine. Again, it's like all MRONJ studies, they're low quality. But you can see that there was, 10 times fold MRONJ development in the patients that didn't have dental care treatment provided before they started the drug. It's a no-brainer in my position. You need to see these patients before they start their bone modifying agent, and there's a tenfold effect of getting MRONJ compared to not getting it. So obviously, look, I know we're getting tighter on time, but these studies aren't perfect. By and large, no MRONJ study is perfect. There definitely are, I would say, ethical responsibilities that a dentist has. So whether someone is starting oncology or any bone regime, they need to see a dentist. They need to have a preventative role in place. And we know from studies that it is exceptionally effective. The other side of it is if someone gets MRONJ, you don't want to get that, and you'll see a lady in a second, Lily. She was identified with MRONJ when she was stage 3. And not only was she stage 3, she had 2 separate sites of stage 3. So secondary prevention means that getting these patients identified early has a better surgical outcome for these patients. And also it allows you to tackle the sites. So say the diabetes, the smoking, the oral hygiene, it allows you to get on that quicker. So secondary prevention is absolutely key when it comes to MRONJ. This is Lily. She was a lovely lady. She had metastatic breast cancer. Originally, she was diagnosed in 2009, 6 or 9. Anyway, she got mets to, multiple bones, and she started on bisphosphonate therapy, initially oral, and then moved on to IV. She had MRONJ stage 3 in both her maxilla and her mandible, and she was treated by, again, like everything that comes with these patients, she was treated by 2 different surgeons in 2 different hospitals, 2 years apart. So Lily had a huge array of treatment, and these are all these are all the things that these cancer patients go through. So when you see the extent of her hormone therapy, chemo, radiation therapy, back on, more chemotherapy, the last thing you want is that these patients get MRONJ because they're at their ends with already. So preventing any problems is where we need to be. This is Lily, lovely lady. She came in with a tissue just under her mandible because there's saliva extruding from it all the time. Her quality of life was deplorable. Her only pleasure was a cigarette, and I don't blame her. Again, stage 3, she had a fistula here up into the sinus. Like the lady has, gone through 10 years of cancer, and we couldn't manage her dental problems to hopefully prevent MRONJ. So this was Lily, and these are the sort of scenarios that you actually see too often when, if this person had just had their teeth dealt with, and if there was secondary prevention on getting her MRONJ identified very quickly, she wouldn't have a fistula, and probably these teeth would be in far better condition. But like these patients with advanced disease, dentistry just falls down the list, and we shouldn't. So again, she had risk factors. She's an oncology patient. She had a denture. She smoked. She was immunocompromised. She was the perfect cocktail for multiple sites of stage 3 MRONJ. And again, you can see just her OPG for completeness, the teeth that have absolutely no hope, and her fistula here. So there we are. Looking at dealing with MRONJ. So I suppose if you have MRONJ, I don't know who's listening, but the chances are you're going to refer it in. But I want just to show you what actually is done with MRONJ patients. So it's short and sweet. What happens to them? Where do they end up? And how do we treat it by and large? So these are some kind of, as I said, I like doing pictures. It allows it to sort of sit in my head a bit better. If someone comes in, you have to take their history, you have to get their radiographs in line. And if you come to a diagnosis of MRONJ and it's stage 1 or stage 2 or stage 3, baseline therapy is chlorhexidine. If it's infected, they need some antibiotics, and you remove any loose bone, because like in that extraction we did, if there's any sort of sharp bone that's poorly vascularized, that's going to traumatize the gingiva and upset the blood supply to the bone, that's not where we want to be. Again, if people are stable, that's great. If they're not stable, they need to progress to non-operative management, which we'll see, or operative management, which is essentially surgery. Again, another diagram, it's very easy to see that actually patients with stage 1 compared to patients with stage 3 have the nearly exact same treatment from a non-operative point of view. You can see that patients have wound care. You might need to give them antibiotics, but by and large, we don't have a whole heap of tricks, that we can treat these patients really effectively. The problem with, I suppose, medications is that we have our usuals like chlorhexidine, we have analgesics and antibiotics, and we have an absolute ream of other medications that people have tried. Now, I'm interested in teriparatide because there might be some evidence to say that it's helping, but hyperbaric oxygen, low laser therapies, no ozone therapies. Penti is a regime that has been shown to be effective to treat ORN. There's a couple of studies that have shown that it's okay when it comes to treating MRONJ, but again, it's not going to be your one sword to deal with MRONJ. And the role of antibiotics are penicillin based, because of usually the actinomyces, what's cultured from them. When we look at the surgical, I suppose, aspect, initially surgery was just there to palliate patients. So it was all about removing small little bits of bone, medical management, overdoing antibiotics, and then suddenly a patient would need surgery because they formed this big sequestra and that needs to be removed. But there's been a big change, to be honest, in the tack and how we deal with them. And you saw how I extracted the tooth. You take no mercy to the bone. You get rid of all of the bad or potentially problematic bone, and you bring it down to the cancellous, good, solid bone that you can close up properly. The literature, actually, a lot of people agree. in our guidance, and you'll see. So tensionless mucosal flaps are absolutely imperative when it comes to the healing potential for these sites, and you have to give them the best chance they can. If you're on the likes of seeing the MaxFax team, you're really looking at bigger surgeries, and you'll see in a little second just one example. So I actually thought, why don't I have more photos of stage 3 MRONJ? And the sad thing was that we probably definitely once a month treated them up in St. James's. So patient, Mets from lung, breast, prostate, they all ended up in hospital for a week. They were NG fed, they went to surgery, they had a large enough surgery, which usually would be something like a decortication or a submarginal bone resection, maybe a rim mandibulectomy. All of these things are removing all the potentially bad bone. And then you ask them to go home and hopefully things heal, which sometimes they do, sometimes they don't. It's a host-based response as well. I have found no proper evidence to suggest that PRGF, growth factors, or anything of the sort will help. What they do offer is a barrier. So you'll see in a patient in St. James's, we used a buccal fat pad, not because it was going to make the bone any better, but it was going to allow a little bit of cushioning for the mucosa and the blood supply on top of the bone. There's loads of studies to say that the piezo actually is very good to help remove bone. I suppose it doesn't heat the bone up as much. And again, there's absolutely no evidence to use PRGF, PRP. We're definitely looking at more successful outcomes in surgery with stage 1 or 2 MRONJ, which is why our secondary prevention absolutely makes the oral surgeon look fabulous compared to struggling trying to treat stage 3 MRONJ. We publish some papers, and it's very clear who the reviewers are, if they're surgically based and medically based. And there definitely is evidence that surgery isn't the answer all the time, and you can get a deterioration in the patient's clinical status, which has to be considered. So some patients are not fit for surgery. Some, like Lily, for example, with her fistula, no one was going to repair that. She wasn't well enough anyway to go through a surgery, and putting these patients even asleep is something. So just because you can do surgery doesn't mean it's always the best option. It'll just help. To conclude, there's treatment and prevention. The right side of things are absolutely imperative in my mind. I don't want to be in the bracket of having to treat MRONJ because there's such an array, there's such a variation, and the response that patients get is not predictable. So we don't want to be there. This is classic patient. You nearly get so used to treating these once every month. This was a lady, she had Mets from breast cancer again. She came from St. Vincent's. She was admitted for a week. She was NG fed. Everything was cleaned up intraorally, and she has this stage 3 MRONJ. So you can see the exposed bone here. This is just a flap raised, and all of this like necrotic bone. So what lies on top here is so deceptive. It's like an iceberg. Once you open it up, you have this huge, like she was numb. You could see, her inferior dental alveolar canal we had to go through it. All of this bone was removed, and suddenly we're into the place of how do we actually get the gum to go back over this. So the great buccal fat pad that's there for God knows what reason came into effect, and that was really good for cushioning and to help the blood supply around the bony defect, which is fairly considerable. So that was the buccal fat pad put into place. You kind of suture it down, and then you close everything up. So that's her at the start, that's her at the end. You can see that we remove some teeth as well. This is not where you want to be. Absolutely, these patients have had enough already, and the response to this type of surgery can be, it can work very well, and also it can't work. So if someone's smoking, that can be the difference between this working and not. We're doing well. I hope everyone's still with me. I am cognizant of the time. So we're on to 50 Shades of Grey. It's not quite as heated as the old film, but our literature is indicative of 50 Shades of Grey. It is rogue, it is unpredictable, and essentially there's so many shades of grey. I actually don't know where to start. So I love the topic of antibiotics. There's some colleagues that, will question my use of antibiotics before and after. And I'll just show you for an example. So these are the big hitters when it comes to guidelines. So, this SDCEP and the Americans, and the Cochrane Review. So SDCEP, absolutely no antibiotic prophylaxis. No, we don't need it. The Americans, ASCO, so they're obviously the big oncology cohort in the States. They can't tell us. They don't know. Inability to draw a conclusion when it comes to antibiotic use with a tooth extraction. The Americans, I like them. They say absolutely, give it pre-op, give it post-op, and use it, and that's fine. And then the Cochrane Review says give them pre-op antibiotics. So you have so many colors and shades of grey in there. It depends on, like all the literature in MRONJ, who do you actually want to listen to? And you just find some literature to support it. And unfortunately, that's the way it comes with MRONJ. Looking for the management then, I suppose it's another grey area. So again, the Oncology Society over in America, they absolutely say, no surgery. We just want conservative management of MRONJ. And only if that MRONJ is going on forever, which means it's stage 2 or stage 3, you should think about doing surgery. And in my opinion, that is, well, that's just allowing harm to happen. The AOMS, again, I like them. They say, right, we definitely need surgery, and I'm going to do you a different algorithm from the maxilla to the mandible, because they're right. The mandible responds more poorly than the maxilla. The Cochrane Review, they give you absolutely no indication of how you should manage them surgically, none. All they say is that fluorescent guided surgery has similar outcomes to conventional surgery. That's great to know. And that they don't advocate PRGF. I wasn't going to use it anyway. So I love the Italians. They're huge in incorporating the dental team, and actually the Italian hygienists, they have multiple guidance on how to treat patients, well, not actually treat MRONJ, but at-risk patients. So they're really good comprehensively. They're very keen on using CT and imaging to define your borders. So that is helpful when it comes to surgery. And then I love it, the EU task force, they say surgery for all stages of MRONJ and get mucosal coverage. So again, absolutely 50 shades of grey. You can get whatever you read. So look, I'll summarize it for you. There's poor guidance for the management of MRONJ. So it's not, like, when you boil it down, there are not enough high quality studies, and that's fine. The treatment planning for BMA patients. So I found that, do you take out the grade 2 mobile? Do you take out the tooth that has, it's half caries, half not? Treatment planning from a restorative point of view has absolutely no direction when it comes to patients with BMA therapy, and they're completely different to your average population. So there's just no one's, I suppose, acknowledging that the treatment plans restoratively wise can be different. Antibiotic therapy, you already saw that. It's a complete mix. The impact of the systemic system and smoking. Smoking, there are studies there, but there's no conclusion, and there's no big hitter on any of those guidelines to properly tackle smoking. The medical management strategies, like, we all know that antiseptics and antibiotics help, but are there other medications that we can take that might, like Penti, that might help revascularization of the bone? You'll be pleased to hear that it's not all doom and gloom and not very grey. There are some decisions made on drug holidays. They're a no-no. Definitely dental reviews for patients that had BMA therapy, 3 to 6 months. Some people say 3, 4, or 6 months. Within that bracket is reasonable. A lot of the guidance says primary wound closure, and that's not just taking out a tooth and putting in a stitch. That's actively reducing the bone and getting that gingiva to come over as close as you can. Chlorhexidine, again, a lot say. The preventative element in a lot of the guidance is elimination of exacerbation factors, which is very reassuring. And then obviously the big hitter in all of this is best practice is prevention. And there's so many studies that show that just simple dental interventions and preventative therapies reduce your incidence of MRONJ, and that's quite reassuring. So where are we now? I suppose the carry on is we don't have a structured pathway for patients on bisphosphonates or bone modifying agents. There is definitely a lack. I mean, our national oral health policy doesn't even mention patients on BMAs. I just think that's catastrophic, to be honest, when you see the morbidity associated with MRONJ. The policy needs to push access to, obviously you can see the National Cancer Strategy, they have their pathway for the oral cancer patients, but the other oncology patients that are on the bone modifying agents, they don't have their say. Dental decay, it's the most common untreated non-communicable disease worldwide. I read that about 4 years ago, and it still hums in the back of my mind. As I said, I did a little bit of research on MRONJ. I was never going to be able to assess MRONJ patients because there's not enough of them. So you flip the coin and you say, right, let's look at something that might be indicative of MRONJ, which is their dental treatment need. So if a patient needs 9 teeth out compared to no teeth out, the chances are the higher dental need will put them at a higher risk of MRONJ. We had 150 patients, a lot were women, a lot had breast cancer, and a lot had periodontal disease. So that for me was a really important finding. There was 86 restorations, and we actually took out 188 teeth in the 150 patients. Like everything, oral cancer screening in all of them, and there was 2 dysplastic results of moderate dysplasia, and some got new dentures. I'll just give you some of the interesting things when we did a little bit of statistical analysis. If you were a current smoker, you were 3.4 times more likely to require an extraction because of periodontal disease. So that reiterates to me, if someone comes in on a bisphosphonate and they're smoking, they're way more likely to require to lose a tooth because of periodontal disease, which also has, I suppose, a link to the development of MRONJ. A lot of these patients didn't have a dentist, and if you didn't have a dentist, you were twice as likely to require a dental restoration. And if you did need restorations, you needed over 2 times more. So that to me says if you don't have a dental home, I go back to the questions I asked originally. If you don't have a dental home, you don't have motivation, you don't have access, you're going to have a higher treatment need and you're at a higher risk of MRONJ. Again, age is a massive thing. All of these patients that are stage 4, they're going to be older, 70s, this bracket. And unfortunately, if you are older, in my study, I found if you increase from 50 to 60, you're more likely to need over 20% more teeth out. 60 to 70, 20% more teeth out. There was nothing to do with MRONJ, but all of these can indicate a risk of how you're stratifying that patient. The last little bit, so emerging concepts, you would hope that for some patients that have MRONJ, there can be a boost from the medical side of things, because surgery, we've tried a lot and there's a huge variation. Teriparatide, that's something that's becoming a little bit in fashion for treating MRONJ. There was a double-blinded randomized control trial that did give some really, I suppose, really positive results, nearly 50% reduction in MRONJ compared to 33 in the placebo group. Again, it might be something that can be used in adjunct with surgery. Again, cone beam, with the advent reduced radiation therapy, we get so much information from cone beams. If I see someone that I know has grade 2 mobile teeth, are on bisphosphonates, the chances are they have MRONJ there already. Take your small volume cone beam CT and know what you're dealing with. So that's really important as well. It's just another tip more than anything. And then suddenly you're not the cause of the MRONJ. You're just removing the teeth that are amidst MRONJ that's present already. So I used this before, and this scrum here, hopefully it'll be happening very soon, is a balance of the flaws, and that's what the development of MRONJ is. If someone smokes compared to someone not, where does that balance lie? I feel like I'm a little bit like the ref there telling everyone to just use chlorhexidine and keep it clean. And that happens with MRONJ. It's a balance of so many things. I'd say you're all like Penno there, about to fall asleep from listening to me for the last hour about MRONJ. So I'll wrap it up and just like to say thank you very much.
Harriet, thank you very much. That was very entertaining. Who knew MRONJ can be as entertaining as how you described it? So thank you very much. Um, I particularly admire how you found a use for the buccal fat pad. That was exceptional.
Love. Yeah.
Um, but in seriousness, I think you're seeing to the ears of much of the special care community, when you were kind of linking in the holistic patient, the person around the diagnosis and the risk of MRONJ, when kind of stratifying them and assessing their risk, involving their social background, their stability. Um, it's something that I think, as special care dentists, we're relatively good at doing, and identifying those people at risk, and less so. But you've kind of contextualized it really well for us by, showing us what to do once that risk is identified. Um, super practical. Thank you so much. Um,
So,
we'll get the questions rolling in, for now. We don't have time for too many, but fire away. First question is, hi, great talk. What antibiotic are you giving pre and post-op?
just a mox, not augmentin, I not metro coma, amoxicillin 5 days before and after. So you'll usually see a patient and I give them the prescription. You tell them on Tuesday to take it, or tell them on whatever day, 5 days before, and then you just give them the 5 days after. As I said, whether it's going to make a huge difference or not, I don't know. But definitely if it's a mandibular extraction, I'd be ta definitely taking I really wouldn't be, I'd be just err on the side of taking it.
Yeah,
Um we're a good
thank you.
community for controlling it. Yeah.
Yeah, that's great. Thank you. If a patient who is high risk for MRONJ has an extraction and you're waiting for healing, would you keep them on antibiotics until healing commences?
No,
No.
no. Once you get antibiotics aren't going to save this problem at all. There's been a heap of extractions that have had antibiotics that turned out horrendous. I think if you can get the operative level right with taking out the tooth properly, you you'll I suppose you'll just give it a better chance. Like that barrier of being able to bring over the gingiva effectively, and keeping a close eye on them, to be honest, that's absolutely key. Not leaving that socket open and not removing that bone is really an nidus of commencement. And look, not everyone's going to get it, but that one person, you don't want anyone getting it, is the bottom
Yeah,
line.
thank you. Um, Margaret had a question. How do medics respond to the diagnosis of MRONJ in your experience in liaising with them?
Um, I did some focus groups, and I think oncology are fabulous. Definitely they are more cognizant of MRONJ. Unfortunately, compared to say, we actually see an awful lot of GP prescribed Prolia caused MRONJ, and it just breaks my heart when people come in with MRONJ and they hadn't a clue about it. Oncology are fabulous, and actually working closely with them, they'll hold that bisphosphonate until you're happy. And I suppose that's a lot of onus on a dentist within this oncology regime, to delay a certain treatment in a person that might have mets to their bone. So they're her very reciprocating of your advice. And that's why I guess I worked with them on the just for the project, because they were so welcoming, and even presenting in oncology meetings and stuff, they definitely respect, I think, the dental service potentially, rather than, unfortunately, I would say, the GP service. There's less awareness of MRONJ. Yeah.
Thanks, Harriet. We have just a couple more questions. What what dosage regime would you use if they were allergic to penicillin?
So I know things have changed. And so KEF is now what you can, or you can use clarithromycin if you want, clindamycin if you want, or Metro. So I would personally, it depends on what the patient is like. You're not going to give them clindamycin if they've GI problems. If they've a penicillin allergy, you can go to your clarithromycin or set, but it's just a standard therapeutic dose. There's no loading. Some people, can do loading, but I think I don't see the point to that. I'd have them on 5 days of it just to help clean up the site a little bit.
Thank you very much, Harriet. As the questions are rolling in, I'm just going to give Neil, the president of the Irish Society for Disability and Oral Health here, just an opportunity to speak about the conference we have coming up this summer, as you can see behind me here. Neil, would you like to take it away?
Thank you. I'd just like to say thank you very much, Harriet. That was a superb presentation, and you had 93 people viewing you at one point, so very well done indeed. And that was really, really good. Yeah, the conference this year, the brochure's almost finished. That'll be coming out in the next couple of weeks. It's at the hotel. You can.
Oh, sorry, I'm gonna finish it off then, if that's all right. But Neil was just saying that the conference is on the 5th and 6th of June in the Royal Marine Hotel in Dún Laoghaire. The theme is kind of taking an approach on looking after yourself through mindfulness exercises and physiotherapy, as well as looking after your patients through different treatment modalities, such as general anesthetic, intravenous sedation, nitrous oxide, the use of penthrox, which is becoming an emerging treatment modality, and local anesthetic. Neil, if you have anything else to add.
No, sorry, I dropped out there. But no, we look forward to seeing you all. Keep on the ISDH website, and we'll give full details in the next few weeks. And we look forward to seeing you all in Dún Laoghaire.
Amazing.
Thank you again, Harriet. That was excellent.
Thank you, Neil. And this webinar will be recorded as well for people who came in late. So tune into our website for an update on when the recording will be available. It should be available sometime next week. And also we have many other webinars recorded as well. So have a look on our website. Couple more questions. Do you have an opinion on long-term doxycycline use in the management of MRONJ?
No. I think that's, I do like an antibiotic, but I think that's the other end of the spectrum. It's not bacterial driven, so it's, it doesn't make sense to keep them on that. You just make them more resistant. But in those cases, if they're recalcitrant and they're not healing, you want to think of most likely a surgical tack to try help even reduce the area of exposure. Yeah.
Maybe one more question. In the future, many older patients will have implants, maybe multiple implants. What are the implications of this for those put on bisphosphonates and similar medications?
Yeah, definitely. The guidance for cancer patients is no. And hopefully they won't have implants. Definitely it is tricky with osteoporosis. And the practice I'm working in, they are doing implants. I think you can't tell them no, because I suppose the risk of MRONJ, number one, it's not fully cited or known, but there's definitely is a risk. But I mean, if a patient is informed that this implant will fail and you can make your bone, you can precipitate MRONJ, it's up to the patient. I personally don't do them, but I have colleagues that I respect and they do them, and there's been no issues so far. I don't think it's as cut and dry. It's like, it depends on what else the patient is going on or where you're putting the implant, or, there's so many other things with implants. If it's, if you've really, even what type of bone you have, whether it's type 1 to type 3. But personally, I don't, and that's just, that's because I don't want to give them, I don't want to cause MRONJ, because I know then if we get it, it's bad to treat. But, yeah.
And yeah, putting the implant in the context of the patient, as you
Yeah,
mentioned multiple times, that's where it's at. Perfect. Thank you so much, Harriet. That was informative and entertaining. So it's a beautiful combination. Thank you. Um, that's great, everyone. Thank you to all for taking some time out of your evenings in the middle of the week to listen to our webinar this evening. Again, tune in for the conference, which will be on our website in a couple of weeks' time, where you can register. And we hope to see many of you there. Thank you very much, and special thanks to you, Harriet. Take care.
thanks. Thanks.
Bye.
Bye.